So I have to wait for some seconds after registration start.
You can start in 3 or 5 seconds, Doctor, okay?
Okay, thank you. Good afternoon, dear colleagues. I wish to thank the organizers for inviting me to this important meeting. My talk today regards the risk of dissemination in the central nervous system in patients with large B-cell lymphomas, and the main strategies to prevent this disappointing event and to treat this event. These are my conflicts of interest. So the central nervous system relapse in lymphoma patients is a rare but fatal and early event, but it is preventable with an adequate prophylaxis. As you can see, the survival curve of patients with central nervous system relapse is significantly poorer with respect to the survival of the overall population of diffuse large B-cell lymphomas. The lymphoma cells can reach the central nervous system by hematogenous route or spreading directly from adjacent bones or by centripetal growth along neurovascular structures. And it affects close to 5% of all patients with diffuse large B-cell lymphoma with a 1 year relapse risk of 5%. Its event is very early and occurs with a median duration time between lymphoma diagnosis and CNS event of 3 to 6 months. And 96% of CNS relapses occurs during the first year of follow-up from diagnosis. Mortality of this event is high. At 1 year, the survival after CNS relapse is only 25%, with a median of 3 to 5 months. Then an early detection and an effective CNS prophylaxis may reduce the relapse mortality. And as the first issue I wish to discuss with you is the identification of the patient at high risk of CNS relapse. Unfortunately, the reported factors and scores exhibits a low diagnosis sensitivity. This is mostly due to a biased selection of the patients, in particular, the exclusion of patients with CNS involved diagnosis in these studies, or the inclusion of varied lymphomas entities. Sometimes the central pathology review was not performed. Moreover, the inclusion of patients treated with different regimens and with different prophylaxis strategy, using sometimes homemade risk criteria, resulted in conclusions that are unreliable and were not confirmed by other studies. Moreover, the prevalence of CNS relapse is strongly affected by the role of extranodal lymphomas. Usually, there are small groups of patients with extranodal lymphomas in the published series, and we know that some of these forms of lymphomas are associated with an increased risk of CNS dissemination. One of the most commonly used parameters to define high-risk patients is the CNS IPI, which includes the 5 variables of the IPI score, that is age, LDH, serolevel, performance status, stage, and the number of external organs involved, with the addition of the involvement of kidneys and or adrenal glands. And with this strategy, we are able to distinguish a high-risk group of patients when these patients had 4 to 6 unfavorable features. In other studies, it's important underline that this score was confirmed both in retrospective and prospective independent series. There are other lymphomas, in particular the extranodal lymphomas, which are with a high risk, that are not considered in the high risk group of the CNS IPI. These are lymphomas that involve areas adjacent to the central nervous system, or the testes or the breast, and other external organs, in particular when are as a part of a disseminated disease. And but most of the extranodal diffuse large B-cell lymphomas are limited stage disease at presentation with a favorable IPI scores, and then this group of patients are not identified by the CNS IPI. Anyway, the number of extranodal sites, in particular more than 2 extranodal sites, are usually associated with a significantly increased risk of CNS dissemination. What about the double hit lymphomas, double expressor lymphomas, and the effect of cell of origin? There are some contrasting results in the literature. There are some studies suggesting that double hit lymphomas are associated with an increased risk, where this was not confirmed in other large prospective studies. And the same can be stated for the cell of origin and for some and for the double expressor lymphomas. The main question on the double hit lymphomas is if this entity is biologically related to an increased CNS dissemination, or if it's simply the result of the fact that the patient with this type of lymphoma usually exhibits several unfavorable prognostic factors. And many of these factors are strongly related with an increased risk of CNS lymphomas. Then it's not possible to understand if this is a biological reason or a clinical reason for this increased risk in these lymphomas. The Goya trial, when the patient received a CHOP with 2 different anti-CD20 monoclonal antibodies, the use of gene expression profiling in combination with the CNS IPI allowed it to identify a group of high-risk patients, which is more or less the less than 8% of these patients, with a 2-year relapse rate of 15%. And this is an important issue because using this strategy, the proportion of patients who need for CNS prophylaxis is significantly reduced. The main problem is that the gene expression profiling is not used in routine practice, and then these results should be confirmed in other prospective studies. In a recently sort of consensus paper wrote by experts from different countries, the high risk of CNS dissemination was related to CNS IPI 3 or more extranodal sites, the involvement of the kidneys, testes, whereas the involvement of the uterus and the breast remains to be confirmed. Regarding the biomarkers, the double hit was strongly related to the selection criteria used in the studies. Then we cannot conclude about the necessity to perform CNS prophylaxis in this type of lymphomas. So the main problem with the prophylaxis is the risk of toxicity, which is different if we use whole-brain radiation, intrathecal chemotherapy, or intraventricular chemotherapy, or intravenous high-dose chemotherapy. And but this is the main reason why we have to use this strategy only in selected high-risk patients. And in the rituximab era, there are different groups of studies focusing on CNS prophylaxis. In the first group, the others used only intrathecal chemotherapy, and they did not observe an advantage in the risk of CNS dissemination. Then this strategy should not be used alone to prevent this event. Conversely, in the series where the CNS prophylaxis was based on methotrexate delivered at high doses, some of these studies did not have a control group, and then we cannot draw reliable conclusions on the role of these drugs to reduce CNS relapse. However, in our experience, when we used we compared the two different groups, those treated before 2007 and after 2007, where we used we don't use CNS prophylaxis, and then we introduced high-dose methotrexate after 2007, we observed an improvement from 12% to 0% of this event. In fact, as you can see, the patient with high risk did not use CNS prophylaxis. The CNS relapse rate was 12%. And in patient treated with high-dose methotrexate to prevent prophylaxis, the CNS relapse rate was 0%, with a significantly improvement in disease-free survival, but also in overall survival in patients with high CNS risk who achieved complete remission after R-CHOP. And this is mostly due to the fact that 1/3 of relapses involved the CNS in our series, and that 1/3 of the deaths were due to CNS relapse in the patient who did not receive CNS prophylaxis. So in the last year, there were several papers published that focused on the role of high-dose methotrexate, and most of these suggested a benefit with this type of prophylaxis. I wish to highlight two studies from the Nordic lymphoma group, because are two prospective studies using high-dose methotrexate and cytarabine after R-CHOP with 4.5% CNS relapse, or more recently, the use of high-dose methotrexate alternated to R-CHOP 14 and followed by intrathecal chemo during R-CHOP and high-dose cytarabine with a 2% CNS relapse rate. Then this experience opened the discussion about which is the best location for high-dose methotrexate, after the conclusion of the chemotherapy or during the induction chemotherapy. And in this sense, there is an international study that compared a large series, 635 patients who received CNS prophylaxis, and at the end of the R-CHOP or similars, and 749 patients where high-dose methotrexate were intercalated with the induction chemotherapy. Even if there were some differences in the patient characteristics, there was not a difference in CNS relapse rate, which was very similar in both groups. Moreover, the use of the intercalated high-dose methotrexate was associated in some patients with an increased risk of toxicity and the risk of R-CHOP delay for 7 days or more. Then the others concluded and suggested to use high-dose methotrexate as prophylaxis at the end of induction R-CHOP immunotherapy. However, in 2021, the Alberta group launched the stone into the pond because they analyzed 906 patients with diffuse large B-cell lymphoma, and the use of high-dose methotrexate did not reduce the CNS relapse rate. But this study shows some limitations. For example, the use of provincial guidelines to define high-risk patients, and the fact that only 1/3 of patients at high risk actually receive high-dose methotrexate. And in most of these patients, the reasons to avoid high-dose methotrexate were not explained. Then it is important to wait for the results of an ongoing randomized trial in Czech Republic that is comparing high-dose methotrexate versus intrathecal methotrexate in diffuse large B-cell lymphoma patients with CNS risk factors of 2 or more. In line with the previous paper, an international group analyzed 2,300 high-risk patients and compared a larger number of patients treated without high-dose methotrexate with 392 patients treated with this CNS strategy. And their CNS relapse rate was very similar, 9% versus 8% at a median follow-up of almost 6 years. However, there were some differences in these patients, in this series. In particular, the group treated with high-dose methotrexate included a larger number of patients with an increased risk of CNS dissemination, in particular with a higher number of involved external organs and with renal, adrenal, testicular involvement, which was significantly more common in this group of patients. Then this comparison that showed no difference may be biased. In particular, for example, there are some subgroup analysis suggesting that also in testicular lymphoma, the use of high-dose methotrexate did not change this CNS relapse rate. But, you know, as Mark Twain said, there are 3 kinds of lies: lies, damned lies, and statistics. In the last 15 years, we tried to improve the results of R-CHOP, adding new drugs, and this strategy was assessed in large international randomized trials. In some of these trials, the effect of the new added drug on the CNS relapse rate was investigated. In particular, with lenalidomide in the REMARK trial, there was not a significant difference in the 2-year central nervous system relapse rate, which was 1% after R-CHOP and 3.3% after R-CHOP plus lenalidomide. And similar results were observed in the Phoenix trial, assessing the addition of ibrutinib, when the CNS relapse rate was 3.5, 3.8, and 2.4% respectively. And by the moment the post-hoc analysis of this event did not show any benefit with the addition of other drugs to R-CHOP. What happens when the central nervous system is already affected? Then we were not able to prevent this event, and we have to treat these patients. The prognosis in the rituximab era is very poor, in particular in patients with CNS plus systemic involvement, and in particular in patients with both CNS and leptomeningeal involvement. Then we have to say that the conventional dose chemotherapy plays a palliative role in the treatment of this event in the published and the retrospective series. The only cured patients with this condition were treated with high-dose chemotherapy supported by autologous stem cell transplantation, in particular when alkylating agent with a good CNS viability were used. Conversely, data on allogeneic transplant are scant, and we have to take into account the balance between efficacy and the high treatment-related mortality of this strategy. Anyway, there are three national single arms phase 2 trials addressing new strategy in these patients, and we can compare these three national trials with the results published on routine practice. And as you can see, the complete remission rate achieved with the different strategies was very poor. It was significantly higher in the Italian trial, with a complete remission rate of 63%, and with a 2-year overall survival of 83%. This was obtained with a combination of high-dose methotrexate plus high-dose cytarabine, 2 doses of rituximab, and 1 intrathecal dose, followed by an intensification with high-dose sequential chemotherapy, including high doses of cyclophosphamide, cytarabine, and VP16, and then tiotepa carmustine conditioned autologous stem cell transplantation. Recently, we reported that the largest international prospective trial in this setting, where we addressed the use of matrix and RISE therapy, followed by autologous stem cell transplantation in patients with diffuse large B-cell lymphoma and secondary CNS involvement, the Marietta trial. Both patients with CNS involvement at diagnosis, at presentation, and at relapse were considered. And then we tried to intensify the treatment with active drugs with good CNS availability. This trial allowed patients with large systemic masses at presentation or at relapse to receive 1 or 2 debulking courses of R-CHOP, and then the patient received 3 courses of matrix and 3 courses of RISE, which is a standard treatment both for patients with relapsed refractory diffuse large B-cell lymphoma, and is active also in patients with primary central nervous system lymphoma. The Wolverine radiation was allowed in patients who did not achieve a response before autologous transplant, and the conditioning regimen included carmustine and tiotepa as currently used to treat primary central nervous system lymphoma. And these were the results. And the Wolf series, the 2-year overall survival was 45%, which was 80% for the transplanted patients. That is very encouraging results for for the patient who achieved the transplantation incomplete or partial response. The tolerability of this treatment were regards mostly some forms of hematological toxicity, in particular when matrix was used. Conversely, as you can see, the non-hematological toxicity was uncommon. Some patients needed for reduction of doses in the treatment, and there were 4 patients who needed for a permanent interruption due to toxicity, with 4 cases of death due to toxicity, that is 6% for these patients. The results were similar both in transformed and de novo diffuse large B-cell lymphoma, and importantly, the subgroup analysis showed that the CNS involved, the patient with the CNS involved at presentation had a significantly better survival with respect to patients with isolated CNS relapse or CNS and systemic concomitant relapse. Moreover, the patient with both CSF and brain parenchyma lesions showed the poorer results, but patient with involvement, CNS involvement at presentation with brain or meningeal disseminations showed excellent results with this strategy. The next steps in central nervous system lymphomas, in particular in secondary central nervous system lymphomas, is to establish important collaborative efforts to investigate molecular markers that predict CNS tropism, to improve the safety and efficacy of CNS prophylaxis strategy, and obviously to improve the efficacy of treatment against both CNS and systemic disease, because the unfortunately failures are equally common in this substance. And let me thank you for your kind attention.